Welcome to the Deep Dive. Have you ever wondered about the incredible, often invisible work your body does every second to keep you safe and heal itself?
It really is amazing.
From a tiny paper cut to fighting off a cold, there's this complex, rapid response system at play.
It's a marvel of biology, truly. We're talking about your body's innate defenses, the built-in security systems you're born with, constantly on patrol against invaders or injury.
Exactly. So if you're curious about the mechanics behind your body's resilience, well, this deep dive is definitely for you. We're unpacking a fascinating chapter on innate immunity, inflammation, and wound healing from Understanding Pathophysiology.
A foundational text.
Absolutely. Our mission today is to distill the most crucial insights into how your body defends and repairs. We want to give you a powerful shortcut to being well-informed.
And we'll guide you through these layers of defense, the dramatic cellular responses, and the incredible healing process. We'll make sure you grasp the core concepts without getting lost in, every single microscopic detail.
Okay.
It's a foundational journey into human biology that really helps you understand your body's true superpowers.
Okay, let's unpack this. Big picture view first.
Yeah.
Our bodies have these amazing lines of defense. Can you give us the quick overview?
Absolutely. Think of it like layered security for a fortress.
Okay.
Your first line of defense, that's like the outer wall. Physical and biochemical barriers, think skin, mucous membranes, stopping trouble right at the surface.
Right, the obvious stuff.
Then, if those walls are breached, the second line kicks in. That's the inflammatory response.
Ah, inflammation.
Yeah, a rapid protective reaction to injury or infection. It's designed to contain the damage and start the cleanup.
And the third.
And finally, the third line, that's adaptive immunity. It's like a specialized, memory-enabled army. It develops over time, remembers specific invaders, and gives you long-term protection.
Gotcha.
But for this deep dive, we're really focusing on those immediate innate responses, the first two lines.
Okay, so the first line, if your skin is the outer wall, how does it actually work? We tend to take these barriers for granted, don't we?
We absolutely do. The first line is both a physical shield and an active chemical defense.
Okay.
Your skin and the linings of your digestive, urinary, respiratory tracts, they're made of these tightly packed cells. That's the physical shield part. But it's not just a passive wall. Your body actively sheds dead cells, trapping pathogens. Mucus traps them too. Then you cough or sneeze them out.
Right.
Or they get flushed away through, urination or vomiting.
So it's constantly cleaning itself too.
Yeah.
What about the chemical side? You mentioned biochemical defenses.
Right. Your body produces this whole arsenal. Sweat, tears, saliva, even earwax. They all contain enzymes that attack bacteria.
Like lysozyme.
Exactly. Lysozyme's a key one. And your skin itself maintains an acidic environment, pH 3 to 5, which most pathogens just don't like.
Makes sense.
And here's where it gets really cool. Your body also produces antimicrobial peptides.
Okay, what are those?
Things like defensins. These are substances that directly kill or inhibit disease-causing bacteria, fungi, viruses, often by messing up their membranes.
Wow. So it's not just a wall, it's like an active chemical combat zone.
Precisely. And alongside all this, we can't forget our normal microbiome.
Ah, yes, the good bacteria. How do they fit in?
They're crucial. These beneficial microorganisms, bacteria and fungi, live on your skin and mucous membranes. They don't normally cause disease. Actually, they actively help you.
How so?
Well, they produce substances that are toxic to pathogens. They compete with the bad guys for nutrients and places to attach, which is often the first step an infection needs.
So they outcompete them.
Exactly. And they even produce essential vitamins for us. But if this delicate balance gets disrupted, say, by taking broad-spectrum antibiotics, then opportunistic pathogens like C. diff or Candida can take over and cause problems.
Right, I've heard of that. Okay, so that's the first line. What happens if it's breached? A cut gets through the skin, for example?
That's when the second line, inflammation, springs into action.
Inflammation. What is it exactly, beyond just something that hurts or looks red?
Well, inflammation is actually a crucial protective response. It's designed to support recovery from injury and disease.
Protective. But it feels so unpleasant.
It does. But think about the goal. When cells or tissues are damaged, this whole cascade starts, getting essential immune cells and proteins right to the site.
To do what?
To destroy any invaders, limit the injury, contain the problem, and kickstart the healing process.
Okay, so fundamentally it's a good thing. even though it involves pain and swelling.
It is, fundamentally. Now, uncontrolled or chronic inflammation, that's definitely harmful and contributes to many serious diseases, no doubt.
Right.
But acute inflammation is rapid, it's usually localized, and it's largely nonspecific.
What does nonspecific mean here?
It means the response is pretty much the same regardless of the type of injury. A cut, a burn, a sprain, a bacterial infection. The immediate inflammatory reaction follows a similar pattern. Unlike that highly specific third line, adaptive immunity.
Got it. So what are those classic visible signs of acute inflammation we all recognize? Redness.
Exactly. They were actually described centuries ago by a Roman named Celsus. You see rubor, which is redness, the area looks flushed.
Okay.
Calor, that's heat, it feels warm to the touch.
Right.
Tumor, which means swelling, the tissue looks enlarged.
Swelling, okay.
Dolor, which is pain, it hurts.
Definitely know that one.
And finally, functio which means loss of function, you can't use it normally.
So what's actually happening underneath the surface?
Yeah.
Microscopically, what causes those signs?
Right at the injury site, in the tiniest blood vessels, the capillaries, venules, microscopic changes begin within seconds.
Okay.
First, you might get a brief constriction, then vasodilation. The blood vessels get wider.
Wider vessels, more blood flow.
Exactly. More blood flow brings more cells and chemicals, and that causes the redness and the warmth.
Makes sense. What about swelling?
That's next. Increased vascular permeability. The walls of the blood vessels become more porous, kind of leaky. Yeah, the endothelial cells lining them contract, creating little gaps. Fluid leaks out from the blood into the surrounding tissue that causes the swelling or edema.
Okay.
And then critically, white blood cell adhesion. White blood cells stick to the vessel walls and then squeeze through those gaps to migrate out into the injured tissue.
The cleanup crew arriving.
Precisely. That influx of phagocytes like neutrophils and macrophages is crucial for fighting infection and cleaning up debris. And all these changes, the pressure from swelling, the chemical mediators contribute to the pain and the temporary loss of function.
This is really orchestrated response. It dilutes toxins, contains microbes, cleans up the mess, and sets the stage for healing. Sounds incredibly coordinated.
It absolutely is. And a huge part of that coordination comes from what the chapter calls the plasma protein systems.
Plasma protein systems. Okay, that sounds complex.
It can seem that way, but the key idea is that three main systems, the complement system, the clotting system, and the Kidman system, work together. They act like a cascade.
A cascade.
Yeah.
Like dominoes.
Exactly like dominoes. One activated protein triggers the next, amplifying the whole inflammatory response very quickly and powerfully.
Okay, let's break them down. The complement system first. What's its main job?
It complements the work of antibodies and phagocytes, hence the name. It's a group of proteins always circulating in your blood in an inactive state. When activated, they can do several things. They can directly destroy pathogens by forming something called the membrane attack complex, which basically pokes holes in them.
Wow.
They can also act as opsonins, essentially tagging bacteria, making them easier for phagocytes to grab and eat.
Like putting a sticky note on them.
Exactly. And some complement proteins act as chemotactic factors, attracting other immune cells to the site. Others trigger mast cells to release histamine, boosting that vascular permeability and dilation.
So it does a lot. How does it get activated?
There are multiple pathways. The classical pathway needs antibodies, linking it to the adaptive immune system. But the alternative and lectin pathways can be triggered directly by microbial surfaces, even without antibodies, so it can jump into action very quickly during an initial invasion.
That makes sense. It seems incredibly powerful, but also potentially dangerous if it goes wrong.
Excellent point. How does the body stop it from attacking healthy tissue? Well, there are tight control mechanisms. Your plasma contains various inhibitory enzymes that rapidly degrade or inactivate these complement proteins and other inflammatory mediators.
Checks and balances.
Absolutely critical checks and balances. Without them, inflammation could cause widespread collateral damage.
Okay. What about the clotting system? We usually just think of stopping bleeding.
And that's vital, of course, hemostasis. But in inflammation, the clotting system does more. It forms this meshwork of fibrin and platelets.
Right, the clot.
That clot traps microorganisms, preventing them from spreading. It also provides a crucial framework, like scaffolding, for repair cells to move in later and start healing.
So it walls off the area and prepares for rebuilding.
Precisely. And it also produces some small peptides that attract neutrophils and increase vascular permeability.
Got it. And the third one, the Kidman system.
The kinin system works very closely with the clotting system. Its main end product is a molecule called bradykinin.
Bradykinin, what does that do?
Bradykinin is a potent molecule. It causes blood vessels to dilate, increases vascular permeability, and importantly, it directly stimulates pain receptors.
Ah, so that's a major reason inflammation hurts.
Yes, bradykinin is a primary mediator of pain and inflammation, so it contributes significantly to those classic signs.
Okay, so we have these powerful plasma protein systems coordinating the big picture. But who are the actual soldiers on the ground, the cells involved?
Right, this is where the cellular components come in the immune army itself. Lots of different cell types are involved. They act right at the injury site to confine the damage, kill any microbes, remove debris, and activate the healing process.
And they need to communicate, right? How do they talk to each other or know what to target?
They use specialized receptors and chemical messengers. The key cells initiating this innate response have what are called pattern recognition receptors, or PRRs.
PR.
Think of these as their eyes or sensors. They're on the cell surface or even inside the cell. They constantly monitor the environment for two main types of molecular patterns.
Which are?
PAMPs, pathogen-associated molecular patterns. These are molecules commonly found on infectious agents like parts of bacterial cell walls.
Okay, signals from invaders.
Exactly. And the other type is DAMPs, damage-associated molecular patterns. These are molecules released from our own cells when they get damaged or die.
So they can recognize both infection and just plain injury.
Precisely. It allows the immune system to respond appropriately, whether there's an active invasion or just sterile tissue damage. A key family of PRRs are the toll-like receptors, or TLRs.
TLRs.
They recognize a wide variety of PAMPs and DAMPs, and when they bind their target, they trigger intracellular signaling pathways that lead to the release of inflammatory chemicals.
Okay, so the sensors detect something. What kind of messages get sent out then?
They secrete cytokines. These are small, soluble signaling molecules, the messengers of the immune system.
Like sending out alerts.
Exactly. Some cytokines are pro-inflammatory, meaning they promote and amplify the inflammatory response. Others are anti-inflammatory, helping to dampen it down and control it.
Ah, the checks and balances again.
Right. And some cytokines, called chemokines, are specifically chemotactic,
Meaning?
meaning they create a chemical trail that attracts specific types of white blood cells to the site of inflammation, like an internal GPS signal guiding the troops.
That's a great analogy.
Important pro-inflammatory cytokines include interleukins like IL-1 and IL-6, and tumor necrosis factor alpha, or TNF-alpha.
TNF-alpha, I've heard of that.
Yeah, TNF-alpha, mainly from macrophages, is a huge player. It's involved in almost any injury or infection response and can even cause systemic effects like fever and muscle wasting if levels get too high. IL-1 is also a major fever inducer, and IL-6 helps the liver produce proteins needed for inflammation.
And the anti-inflammatory ones.
T1s are IL-10 and TGF-F. They help regulate and eventually resolve the inflammatory response, preventing it from going overboard.
So it's a balance.
It's all about balance. We also have interferons, IFNs, which are crucial for fighting viral infections. Type I interferons warn neighboring cells about viral threats, and type 2 interferon activates macrophages.
Okay, let's talk about the specific cells then. Who are the special forces that kick things off?
A really significant initiator is the mast cell. These guys are stationed in connective tissues strategically located near blood vessels.
Ready to act.
Exactly. When they get stimulated by injury, by certain immune complexes, by complement fragments, they rapidly release potent biochemical mediators in two main ways.
Okay.
First, degranulation. They dump the contents of their granules almost instantly. This includes things like histamine.
Histamine.
Allergy symptoms, right? Yes, but it's also crucial in inflammation. Histamine binds to receptors on blood vessels, causing that vasodilation and increased permeability. It also attracts other white cells like neutrophils and eosinophils.
So it's a key early player. What's the second way mast cells act?
They also synthesize new mediators on demand. These take a bit longer to produce but have longer-lasting effects. Examples include leukotrienes and prostaglandins.
Prostaglandins. Aren't those related to pain and fever? And targeted by drugs like aspirin?
Precisely. Prostaglandins contribute to increased vascular permeability, neutrophil chemotaxis, and importantly, pain. NSAIDs like aspirin work by inhibiting the enzymes, COX enzymes, that synthesize prostaglandins. Leukotrienes also increase permeability and cause smooth muscle contraction, like in asthma.
So mast cells are like the initial alarm bell and orchestrators of the ongoing response.
You could definitely see them that way. Then we have the endothelial cells lining the blood vessels. Normally, they keep things flowing smoothly, but during inflammation, they become permeable and express adhesion molecules that grab onto passing white blood cells.
Helping them get out into the tissue.
Exactly. And even platelets, which we mostly associate with clotting, play a role. They release mediators and growth factors that contribute to inflammation and later healing.
Okay, what about the main white blood cells we always hear about? The fighters.
The first responders are the neutrophils. They're the most numerous phagocytes in the early stages, usually arriving within 6 to 12 hours.
The shock troops?
Kind of. They're short-lived, highly mobile, and specialize in phagocytosing bacteria and removing debris. They're a major component of pus.
Cuss, right. What about others?
Eosinophils are mildly phagocytic, but are key players against parasitic infections and also help regulate mast cell mediators. Basophils are less common, but function similarly to mast cells, releasing histamine.
And the big guns for longer-term cleanup and coordination.
That would be the monocytes circulating in the blood. When they migrate into the tissues, they transform into macrophages.
Macrophages, the big eaters.
That's what the name means. They arrive later than neutrophils, typically 3 to 7 days after injury, but they live much longer and are incredibly powerful phagocytes.
What else do they do besides eat debris?
They are crucial orchestrators of the later stages. They continue the cleanup, but they also release growth factors that promote new blood vessel formation, angiogenesis, and stimulate fibroblasts to start building scar tissue. They essentially manage the transition from inflammation to healing.
And you mentioned dendritic cells.
Yes, dendritic cells are also phagocytic and are strategically located in tissues. Their key role is capturing antigens, pieces of invaders, and then migrating to lymph nodes to present these antigens to T lymphocytes.
So they bridge the gap between this innate response and the adaptive immune system.
Exactly. They are crucial antigen-presenting cells initiating that more specific long-term immune response. And we shouldn't forget natural killer NK cells. They are a type of lymphocyte involved in innate immunity, primarily targeting virally infected cells and tumor cells.
So how do these phagocytes, neutrophils, and macrophages actually eat the invaders and debris? You mentioned phagocytosis.
Right, phagocytosis. It's a multi-step process.
Okay.
First, the phagocyte has to get to the site. That involves margination sticking to the blood vessel wall and diapedesis squeezing through the gaps between endothelial cells.
Getting out of the blood.
Then, chemotaxis following those chemical trails, the chemokines, to the site of injury.
Like following breadcrumbs?
Pretty much. Once at the site, there's recognition and adherence. The phagocyte has to recognize the target and bind to it. This step is often greatly enhanced by opsonization.
Opsonization, that tagging thing again.
Exactly. Opsonins, like certain complement proteins, C3b or antibodies, coat the target. Think of them as molecular handles or glue that makes it much easier for the phagocyte's receptors to grab onto the microbe or debris.
Makes it easier to eat?
Yes. Next comes engulfment. The phagocyte extends projections, called pseudopods, around the target and pulls it inside, forming a membrane-bound sac called a phagosome.
So it swallows it whole.
Essentially, yes. Then comes fusion. Organelles inside the phagocyte, called lysosomes, which are packed with destructive enzymes and chemicals, fuse with the phagosome. This creates a phagolysosome.
A killing chamber.
You could call it that. Finally, destruction. Inside the phagolysosome, the target is destroyed through various mechanisms. Some rely on oxygen, producing toxic reactive oxygen species like hydrogen peroxide, the respiratory burst. Others are oxygen independent, using acidic pH, enzymes, and proteins that damage bacterial membranes.
That's quite a process. I read that even these phagocytes dying can cause some tissue damage.
They can. As neutrophils die off, they can release some of their potent enzymes, which can contribute to local tissue damage. But the body has ways to limit this, like antioxidants and enzyme inhibitors. A fascinating clinical link here is alpha-1 antitrypsin deficiency, an inherited condition where you lack a key inhibitor, leading to uncontrolled neutrophil enzyme activity and chronic lung inflammation, like emphysema.
Wow. Okay, so inflammation is supposed to be temporary, protective, but you mentioned chronic inflammation earlier. What's the difference between acute and chronic?
The key difference is really duration and the underlying process. Acute inflammation is typically rapid onset, relatively short duration, maybe hours to days, usually resolving within 8 to 10 days if things go well. It's characterized by those vascular changes, edema, and neutrophil infiltration. The goal is to eliminate the threat and initiate healing.
Self-limiting, ideally.
Ideally, yes. If it's successful, you get resolution and healing.
And if it's not successful?
That's when it can transition into chronic inflammation, which lasts for weeks, months, or even years.
Why would it become chronic?
It can happen if the initial injurious agent persists, like certain hard-to-kill bacteria, TB bacteria, for example, or a foreign object like a splinter that isn't removed. It can also result from repeated bouts of acute inflammation, or sometimes it can arise slowly on its own without a distinct acute phase, maybe due to persistent irritation or an autoimmune reaction.
What does chronic inflammation look like cellularly? Is it different from acute?
Yes, the cellular picture changes. Instead of neutrophils dominating, chronic inflammation is characterized by a dense infiltration of lymphocytes and macrophages. These cells are longer-lived and orchestrate a different kind of response, often involving simultaneous tissue destruction and attempts at repair, frequently leading to scar tissue formation, fibrosis.
And you mentioned granulomas earlier in the context of chronic inflammation.
Right. A granuloma is a specific type of chronic inflammatory response. It happens when macrophages encounter something they can engulf but can't easily destroy, like the tuberculosis bacillus or certain fungi.
So the body tries to wall it off.
Exactly. It's an attempt at containment. Macrophages cluster around the persistent agent. Some transform into large fused cells called multinucleated giant cells, and others become epithelioid cells. This core is surrounded by lymphocytes, and the whole thing often gets encased in fibrous connective tissue.
Like building a little fortress around the problem.
That's a good way to think about it. While it contains the threat, the granuloma itself can take up space and damage surrounding tissue, impacting organ function, like you see in the lungs with PP. Sometimes the center of the granuloma can undergo necrosis, becoming cheese-like, caseous necrosis, or even liquefaction necrosis.
Fascinating, but sounds problematic.
Okay.
So let's shift gears. Assuming inflammation does resolve, whether acute or chronic, the goal is healing, right? Wound repair.
Absolutely. That's the ultimate objective after the threat is neutralized and the debris is cleared.
What's the best possible outcome for healing?
The most favorable outcome is resolution, or regeneration. This means the damaged tissue returns completely, or almost completely, to its original structure and function.
Like nothing ever happened.
Pretty much. This is possible when the injury is minor, there's minimal tissue damage, and the affected tissue is composed of cells that can readily divide and replace themselves, like the epithelial cells of the skin or the lining of the gut, or even liver cells to some extent.
But that's not always possible, is it?
No, unfortunately not. If the damage is extensive, if the supporting structures of the tissue are destroyed, or if the tissue is made of cells that can't regenerate, like neurons in the brain or cardiac muscle cells after a heart attack, then repair occurs instead.
Repair versus regeneration, what's the difference?
Repair involves replacing the destroyed tissue not with identical tissue, but with scar tissue.
Scar tissue, mostly collagen.
Primarily collagen, yes. It's laid down by fibroblasts. Scar tissue provides tensile strength and fills the defect, restoring structural integrity. However, and this is key, it usually can't perform the specialized physiological functions of the original tissue.
So you get strength back, but maybe not the original function.
Exactly. Think of a scar on your skin. It's strong, but it doesn't have hair follicles or sweat glands. A scar in the heart muscle after a heart attack can't contract like normal heart muscle. So repair often leads to some degree of functional loss.
The chapter also talks about primary intention versus secondary intention healing. What's that about?
This describes how wounds heal based on their characteristics. Primary intention healing occurs in wounds that are clean, have minimal tissue loss, and where the edges are closely approximated. Think of a clean surgical incision that's been sutured shut, or a simple paper cut.
The edges are brought together.
Right. Healing happens relatively quickly, with minimal scarring, mainly involving epithelial regeneration and sealing the gap.
Okay. What's secondary intention then?
Secondary intention is for wounds that are much larger, have significant tissue loss, are maybe contaminated, or where the edges can't be easily brought together. Think of a large pressure ulcer, a severe burn, or an extraction socket in your gums.
So much bigger, open wounds.
Yes. These wounds have to heal from the bottom up. It requires a lot more tissue replacement. You see a much larger amount of granulation tissue formation to fill the defect, followed by wound contraction, where the wound edges pull together, and finally epithelialization over the top. It takes much longer and results in a larger, more noticeable scar, and even the best scar tissue only regains about 80% of the original tissue's tensile strength.
Okay, regardless of primary or secondary intention, what are the actual phases of wound healing itself? It sounds like a complex process, too.
It is, and it's fascinating. It's generally described as occurring in overlapping phases. Sometimes 3, sometimes 4 phases are described, but let's go with 4.
Okay, phase 1.
Phase 1. Hemostasis, coagulation. This happens immediately after injury. Blood vessels constrict briefly, then dilate. The coagulation cascade kicks in, platelets aggregate, and a fibrin clot forms. This stops the bleeding, provides that initial scaffold for healing cells, and platelets release growth factors that signal the start of the next phase.
Stop the bleeding, lay the foundation. Got it. Phase 2.
Phase 2, inflammation. Within minutes to hours, the inflammatory response we discussed takes over. Neutrophils arrive first to clean up debris and bacteria. Then macrophages come in, continuing the cleanup, but also releasing crucial growth factors to orchestrate the next phase. This phase clears the way for repair.
Makes sense. Inflammation prepares the site. Phase 3.
Phase 3, proliferation and new tissue formation. This usually starts around 3 to 4 days after injury and can last for weeks. This is the rebuilding phase.
What happens here?
Several key things. Macrophages are still active, clearing debris, but also heavily promoting angiogenesis, the formation of new blood vessels. These new capillaries grow into the wound bed, creating that pink, granular-looking granulation tissue.
Ah, granulation tissue. That's a sign of healing, right?
Yes, it's healthy tissue filling the wound. At the same time, fibroblasts, recruited by growth factors, migrate into the area and start synthesizing and depositing collagen, the main structural protein for the scar. This requires nutrients like protein, vitamin C, iron, and oxygen.
Building the new framework.
Exactly. And epithelial cells at the wound edges migrate across the granulation tissue bed to cover the wound surface. That's epithelialization. Some fibroblasts also differentiate into myofibroblasts, which contain contractile fibers. These cells help pull the edges of the wound together, causing wound contraction, which is especially important in secondary intention healing.
Okay, rebuilding phase. What's the final phase?
Phase 4, remodeling and maturation. This phase begins after the wound is closed and can last for weeks, months, or even up to 2 years.
2 years, wow.
Yes, it's all about refining the scar tissue and recovering as much normal tissue structure and strength as possible. Collagen that was deposited hastily in phase 3 is now reorganized, degraded, and replaced with stronger, more aligned collagen by fibroblasts. The cellular activity decreases, many of the new capillaries regress, so the scar eventually becomes less red and more vascular, pale. The scar tissue gradually gains tensile strength during this phase, though it rarely reaches 100% of the original.
That's an incredibly complex and long process. What happens if something goes wrong? The chapter mentions dysfunctional wound healing.
Yes, unfortunately, healing can be impaired by many factors.
Like what?
Ischemia, lack of sufficient blood flow and oxygen, is a major one. It hinders energy production and collagen synthesis and increases infection risk. Excessive bleeding can create large clots, hematomas, that physically obstruct healing and act as a growth medium for bacteria.
Okay.
Excessive fibrin deposition can sometimes lead to fibrous adhesions, which are bands of scar tissue that can form between internal organs, especially after surgery, potentially causing pain or bowel obstruction.
That sounds nasty. What about underlying health issues?
Absolutely critical. Predisposing disorders like diabetes mellitus significantly impair healing. High blood sugar affects leukocyte function, reduces oxygen delivery, and suppresses macrophage activity. Obesity is also linked to impaired healing, possibly due to poor blood supply and fat tissue and altered leukocyte function.
Nutrition must be important too.
Extremely. Inadequate nutrition, especially lack of protein, vitamin C, essential for collagen synthesis, vitamin A, zinc, and iron, can severely delay healing.
And medications.
Yes, certain medications can interfere. Anti-inflammatory drugs like steroids suppress macrophage migration and inflammation needed for healing. Some cancer chemotherapies inhibit cell proliferation. Even NSAIDs might affect healing, possibly promoting excessive scarring in some cases. And tobacco smoking is hugely detrimental. Nicotine causes vasoconstriction, reducing blood flow, and other toxins impair healing processes.
That's a long list of potential problems. What about issues with the scar tissue itself, those really prominent scars people sometimes get?
Right, that relates to dysfunctional collagen synthesis during the remodeling phase. A hypertrophic scar is raised and often red, but it stays within the boundaries of the original wound. These often tend to regress somewhat over time.
Okay, and the other kind?
The more problematic one is a keloid. A keloid is also a raised scar, but it grows beyond the original wound boundaries, invading the surrounding normal skin like a benign tumor. They're often itchy or painful, have a high recurrence rate after surgical removal, and there seems to be a genetic predisposition, being more common in individuals with darker pigmented skin.
Wow, that sounds difficult to manage. The chapter also mentions wound disruption and contracture.
Yes. Dehiscence is when a wound, particularly a sutured surgical wound, pulls apart at the suture line. It typically happens 5 to 12 days post-op, often due to infection, excessive strain on the wound, or poor healing conditions like obesity or poor nutrition. It can range from superficial skin separation to the underlying tissues also opening up.
That sounds serious. And contracture.
Contracture is an exaggeration of the normal wound contraction process. Excessive shortening of the scar tissue leads to deformity and can severely limit joint mobility, especially over joints or after large burns. It can also happen internally, like causing strictures in the esophagus.
Okay, one last area the chapter touches on is age-related factors. How do these processes differ in newborns versus the elderly?
Good question. Innate immunity and healing definitely vary across the lifespan.
How do newborns fare? Are their systems fully developed?
Not entirely. Newborns, especially premature infants, have somewhat immature immune systems. Their inflammatory responses can be transiently depressed, they may produce fewer cytokines, and their neutrophils might not be as efficient at chemotaxis moving towards the infection. Complement levels can also be lower. This combination makes them more susceptible to certain types of infections.
So they're more vulnerable initially.
Yes, although they do get some passive immunity from their mothers. And interestingly, the chapter notes that things like vaginal birth and breastfeeding help establish a healthier gut microbiome compared to C-section births or formula feeding, which impacts immune development.
And at the other end of the spectrum, the elderly.
In older adults, the situation is a bit different. While the numbers of immune cells might be normal, their function can be diminished. Phagocytes might be less efficient, cytokine production can be altered, leading sometimes to increased chronic low-grade inflammation but impaired acute responses.
So more chronic inflammation, but maybe less effective acute response.
That seems to be the pattern. They are also at much higher risk for impaired wound healing. This is often multifactorial due to coexisting chronic illnesses like diabetes or cardiovascular disease, which affect blood flow, increased use of medications like NSAIDs or steroids, reduced skin thickness, and subcutaneous fat, which affects protection and perfusion, and potentially nutritional deficiencies.
All those factors we discussed earlier can be more common in older adults.
Exactly. It all contributes to slower, less effective healing and increased susceptibility to wound complications. It also impacts things like vaccine effectiveness, which is why, for instance, the flu vaccine dose is often higher for the elderly to try and elicit a stronger immune response.
Wow. That was a really comprehensive deep dive into the body's first lines of defense, inflammation, and the whole healing process, from the skin barrier to the complexity of granuloma or a keloid. It's incredible.
It truly is. It highlights the sheer complexity, but also the resilience of our biology. Understanding these foundational processes gives you such a profound appreciation for what your body is doing, mostly without you even noticing every single second.
It really does. And thinking about that bigger picture, how all these pieces have to work together. The barriers, the alarm signals like histamine and cytokines, the different cell types arriving at just the right time, the protein cascades. If even one part is off.
The consequences can be significant. Delayed healing, chronic inflammation, increased susceptibility to infection. It really underscores how interconnected everything is.
It makes you appreciate health and even just the healing of a small cut in a whole new way, that constant, intricate dance of defense and repair.
Absolutely. These systems are constantly working, adapting, protecting. It's fundamental to our survival.
Well, thank you for guiding us through that. This has been incredibly informative. We hope everyone listening feels much more informed and maybe even a bit awestruck by the amazing world inside their own body.
It's always fascinating to explore.
Until next time, keep digging, keep learning, and keep being amazed.